We have some factors to be considered for successful treatment of the furcation involvement. The degree of involvement, whether class 1, 2, or 3, crown-root ratio, the length of the root, anatomy and morphology of the root, the degree of their separation, strategic value of tooth in the dental arch, residual tooth mobility, need for endodontic treatment, prosthetic requirement, periodontal condition of the adjacent teeth, ability to maintain the oral hygiene, quality of bone and ability to place implants, functional consideration, long-term prognosis. The main objectives of furcation involvement correction is the elimination of microbial plaque from the root complex, establishment of an anatomy to facilitate proper self-performed plaque control, and prevent the further attachment loss. Therapeutic classes of furcation defect. It's categorized into three main classes, and according to them, we're going to make the treatment. Degree 1, either non-surgical treatment or making furcation plasty. Furcation number 2, furcation plasty, tunnel preparation, root resection, extraction, guided tissue regeneration, gain. Furcation type 3, either tunnel preparation, root resection, or tooth extraction. We're going to discuss those briefly. The non-surgical therapy, it's like a balanced scale. We must both have oral hygiene instruction together with scaling and root planing. The oral hygiene instruction including the use of proxy brush or the interradicular brush, this type of brush that is used to clean the furcation area. It's used for plaque removal into the furcation lesion. Also, we have the water pick. This device is designed for making low pressure delivery of therapeutic rinses below the gum line. It comes with different heads, so we instruct the patient to use the head that is suitable for his status. Perio aid, also used in the furcation to remove plaque. This is the perio aid. Scaling and root planing as a rule, it must precede all types of periodontal therapy. We have different types of instruments used for this purpose, like the quid furcation or curate. We have the diamond-coated files, the DeMarco curate, and the Mini 5 Gracie curate. This type of file, or diamond-coated file, used for facial and lingual adaptation. Another type here, where the blade is set at opposite angle, which fits the mesial and distal. And this type, which is called teardrop-shaped, cover wide area in the tight mesial and distal areas. Surgical therapy. Surgical therapies can be osseous resection, regeneration, tunnel preparation, furcation plasty, root resection, hemisection, extraction, and finally dental implants. Starting with the osseous resection, including the osteoplasty and ostectomy. As we discussed in the previous seminars, the osteoplasty means the reshaping of the alveolar process, and ostectomy means the removal of some alveolar bone. However, those procedures are used to make the area of furcation cleansable, like we are making purposely changing the severe or advanced class 2 and 3 into class 4 and exposing the furcation into the oral environment so it could be easily maintained and cleaned. In those pictures, we can see a buccal preoperative view for this maxillary first molar. In this picture, a buccal flap, a full mucoperiosteal flap elevated, and we can see the buccal ledge and the class 2 buccal furcation. This is the defect. After buccal correction, removal of any granulation tissue, diseased tissue, soft and hard bacterial deposits, making minor astectomy over the root prominence to reduce a positive architecture, to produce, a positive architecture. And this picture is 10-year postoperative view of soft tissue form with minimal bucket depth is present. Furcationplasty. It is a resective surgical procedure that is associated with osteoplasty and odontoplasty. The osteoplasty is the reshaping of bone, and odontoplasty removal of some tooth substance to widen the furcation area. The purpose of this procedure is to establish soft tissue papilla like this, which is covering the entrance of the interradicular periodontal tissue. Procedure starting with local anesthesia and then reflecting of the mucoperiosteal flap, then removal of some hard and soft bacterial deposits, odontoplasty using handpiece and Fisher burr to widen the narrow entrance, and then osteoplasty by reshaping the bone and getting the good architecture, and then repositioning of the flap and sutured. Another procedure is the tunnel preparation, which means we're purposely making class 4 furcation from the deep class 2 and 3 and make the furcation area accessible for oral hygiene procedure. The disadvantage of this type of procedure is sensitivity, development of root caries, exposure to lateral canals that will require endodontic therapy in the future. The patient should have good manual dexterity to maintain optimal oral hygiene, because it mostly depends on the patient's compliance and his ability to maintain the area clean. Tunnel preparation technique steps will be discussed here in this case report. This is a case of 38-year-old female patient attended to the dental clinic suffering from pain and swelling on left mandibular molars. On clinical examination, they found that the patient has very poor oral hygiene, gingival inflammation, and deposition of plaque and calculus all over her teeth. Also, there was a lingual swelling in the mandibular areas, which is not obvious in this picture. On probing, there was 7 mm deep periodontal pocket around the furcation area. Motivation and instruction given to the patient to be restricted to a very good oral hygiene and home care, and then scaling and root planing performed. Following a few weeks, the patient attended with good oral hygiene and a good gingiva to make the surgical procedure. Here, a buccal and lingual flap elevated, and then removal of the bacterial deposits through root planing. Furcation then widened and recontoured by removing some interradicular bone, also some mesial and distal bone removed to get a flat out line. After that, the flap is replaced apically and sutured. Pack is placed, and then after 1 week, the suture is removed. This picture is 6 months postoperatively. We can see here the patient is restricted to a good oral hygiene and the teeth are clean. Instructions. After removal of the dressing, the patient was told to maintain the tunnel area plaque-free with interdental brush, rinsing with 0.12% chlorhexidine diglyconate solution for 4 to 6 weeks, daily rinsing with 0.025% sodium fluoride solution and the use of fluoride dentifrices applied directly by the intraradicular brush was also recommended because we know that some of the tooth substance is removed and we don't want to get tooth caries. While such treated areas are more prone for caries, so the patient followed regularly for 3 to 6 months and maintenance visit for a period of 1 year and follow-up. Now, another procedure for correction of furcation involvement is the elimination of the furcation. This is done either by root resection and separation, tooth division, or hemisection. Root resection means the removal of one or more roots from the multi-rooted tooth to allow access to the furcation area for cleaning. So in the root resection, we are removing a root, while the root separation means sectioning of all roots and maintain them all. This used in deep grade 2 and grade 3 involvement. Sequence of treatment including first performing endodontic treatment. In case of resection, we do endodontic treatment for the root that we are going to preserve, and in case of separation, we are doing endodontic treatment for all roots. Provisional restoration to keep the canal orifice sealed, and then the procedure we are performing, then periodontal surgery, and finally the restoration. The technique of resection is discussed here on this diagram. For this maxillary first molar with defected distal buccal root and furcation involvement of grade 2 buccally. Here we have a crater between the first and the second molars. In this picture here, there is a removal of a bone from the facial side of the distal buccal root and exposure of the furcation for instrumentation and removal of bacterial deposits. And then an oblique cut is made with handpiece to cut the distal buccal root from the palatal and the mesial roots. We can do more horizontal section when we have vital root because it exposes less of the pulp of the tooth. Now the resected root is removed and finally the area is contoured and flap replaced and sutured. In this clinical case here, we can see that we have furcation involvement in the second and first molars. The defected one, or the defected root here, is the mesial root of the mandibular second molar. So the decision was to remove it. After reflection of the mucoperiosteal flap, buccally and lingually, and removal of some bone, the resection is done obliquely to remove the mesial root of the mandibular second molar. After removal, the area is reshaped and cleaned, and then the flap is repositioned, sutured, the second molar fixed to the first molar for more support, and this is picture after healing. The indications and contraindications for root resection were well summarized by Basarab. Teeth that are critically important to the overall dental treatment must be maintained, and teeth that have a sufficient attachment remaining for function, which means it won't be compromising the function. Teeth for which a more predictable or cost-effective method of therapy is not available. It means that the patient already undergone treatment, procedure, and cannot afford for additional costly procedures and willing to keep his tooth. Teeth in the patient with good oral hygiene and a low activity of caries are suitable for root resection, and the patients unwilling to perform good oral hygiene and preventive measures are not suitable for such procedures. So we should always be clear to the patient about the available treatment measures and the costs and outcomes of the treatment. Which root should we remove? When we select the root that we will remove, we don't do this, of course, roughly. We have rules to follow. First, we should remove the root that eliminate the furcation and maintain architecture for the remaining roots. We should remove the root that is mostly affected, with the most amount of bone and attachment loss. We should remove the root to maintain the adjacent affected tooth. For example, for this, when we have maxillary first molar that is presented with class 3 buccal furcation involvement, and adjacent to it the second molar presented with two-walled intra-bony defect. So the decision here will be the removal of the distal buccal root of the first molar in order to have access for the instrumentation and maintaining of the second molar. 4. We should remove the root with the greatest number of anatomic problems that complicate the endodontic and periodontic treatment, like those with severe curvatures, developmental grooves that interfere with maintaining the area clean, and plaque deposition, root flutings or accessory, and multiple root canals. 5. We should remove the root that least complicates the future periodontal maintenance. Now another procedure is the tooth division. It means the conversion of the two-rooted molar into two single-rooted teeth. The indication for this is the extensive furcation involvement of lower molar when bone loss around both roots is similar. When we have the bone loss on both roots similar, we decide to make the tooth division. The procedure including endodontic treatment, of course, as we mentioned in the previous slides, raising buccal and lingual flaps, making tooth division with burrs starting from the roof of the furcation through the crown, then each half prepared to receive crowns after healing period. Hemisection means the removal of the whole root with its crown portion. Indication including lower molars where there is extensive bone resorption around one of the roots. It is opposite to the decision of tooth division. The procedure always, as we said, endodontic treatment, raising buccal and lingual flaps, making tooth division with burrs starting from the roof of the furcation upward through the crown, then removal of one of the two roots, the remaining roots scaled and planned, and then the remaining crown carefully contoured and smoothed, flaps repositioned and sutured, and after healing, tooth can receive crown or forming part of a bridge.